Hi, good evening, everyone. As you all know, I'm going to continue with part 2 of differential diagnosis of oral and maxillofacial lesions. Last time we covered red and white lesions, and today we'll be covering difference, that is petechial, ecchymotic, and telangiectasic lesions, blue and purple lesions, brown, gray, or black lesions, and last yellow lesions. So starting with the meaning of petechiae, purpura, and ecchymosis. So when a traumatic event results in hemorrhage, there is entrapment of blood within the tissues, and different terms are used depending on the size of this hemorrhage. So minute hemorrhages into the mucosa, that's pinpoint hemorrhages, they are called as petechiae. If they're slightly larger area, then the hemorrhagic area is called as purpura. And if the accumulation of this hemorrhage area is greater than 2 centimeters, it's called as ecchymosis. And if the accumulation of blood within the tissue produces any mass, like this one, it's called as hematoma. As you can see, this hematoma is a dark purple nodular mass in the buccal mucosa of a patient who is on warfarin therapy. And this lesion is healed totally in 8 days after the medication was discontinued. So I hope you know what's the difference between petechiae, purpura, and ecchymosis. It's purely depending upon the size of the lesions. So the first lesion is the petechial lesions. These lesions usually are seen on the soft palate. It can be because of various reasons, like violent coughing, which is going to produce trauma to the soft tissues, that is the soft palate, and that injury can lead to pinpoint bleeding here. And as you see, this is another lesion because of fellatio. This also causes submucosal hemorrhage and results in petechial lesions of the soft palate. So it can be non-specific trauma. If you know the reason, then we name it as a petechiae formed by that trauma. The next disease which can cause petechiae in soft palate is infectious mononucleosis. It is a symptomatic disease which is caused by the exposure to Epstein-Barr virus. And adults contract this virus through direct salivary transfer. That can be because of sharing of straws or kissing, hence the name kissing disease. This is called as kissing disease because it is simply spread by salivary transfer. And in children, it can be sometimes asymptomatic, but when it is symptomatic, it is accompanied by fever, high fever of 104 degree Fahrenheit, and there is always symmetrical cervical lymphadenopathy. And more than 80% of these young adults have tonsillar enlargement. So how to differentiate it as a disease from these caused by trauma is you will usually have a tonsillar enlargement, like in here you can see, and sometimes this tonsil which is enlarged is covered by exudates, as you see in this picture. And these petechiae usually disappear within 1 or 2 days. And when you see that the whole entire disease can be gone and resolved within 4 to 6 weeks. And during this time, we can symptomatically support the patients by giving antipyretic and painkillers, just to minimize the symptoms. The next condition is hereditary hemorrhagic telangiectasias. Now, what is the meaning of telangiectasias? They are simply the small collections of the dilated capillaries. And this is called as telangiectasias, a group of dilated capillaries. This is an uncommon condition which is autosomal dominant. And how do I know that the patient is suffering from hereditary hemorrhagic telangiectasias? Out of the following 4 which I'm going to mention, at least 3 of them should be positive, or like 2. One is there is recurrent spontaneous epistasis, meaning there is recurrent spontaneous bleeding from the nose. The patient gives a history of that. And the patient also presents with a family history of hereditary hemorrhagic telangiectasias. And the patient has the skin or mucosal lesions, which looks like this. And the patient can also have arteriovenous malformations of different organs like lungs, liver, CNS. So these are the four, and it can be caused by an autosomal dominant disorder, and the patient can present with any of these four conditions. So this is a tongue which shows multiple red papules, and they can also be seen in the buccal mucosa. And now what is this picture saying? This is called as a diascopy test, wherein you take a slide and try to compress on these lesions. If it is filled with blood, that is vascular lesions, it causes blanching in the center. Or sometimes when it is tiny as the scapulary, this can totally disappear. This is called as positive diascopy test. You can simply confirm that it is a vascular lesion, sorry. So if it is a mild condition, this requires no treatment. If it is moderate to severe, then surgery, cryosurgery, or surgical management is the mode of treatment. Now, why is this important to the dentist? Few authors have suggested that the patients who are suffering from this condition should be given prophylactic antibiotics before the dental procedures, similar to that of infective endocarditis, whatever protocols we follow. And the reason for this is few patients who have undiagnosed arteriovenous malformation can have a chance of brain abscess. And if we treat any conditions which can cause bacteremia, then these patients will end up having brain abscess, which is deadly. So to prevent that, dentists are usually asked by some authors to have antibiotic prophylaxis for such patients. And whenever surgery or extraction is indicated in these patients, they have to be mostly followed by blood replacement or iron therapy, because there is increased blood loss in these patients. The next is idiopathic thrombocytopenic purpura. So in these patients, usually this is diagnosed during the childhood, and it usually occurs immediately after a viral infection, and that can be non-specific viral infections. The symptoms appear very quickly and they can be severe. And these lesions are not life-threatening. They can resolve spontaneously within 4 weeks to 6 weeks. And if it is existing for longer, it can take up to 6 months, but not longer than that, to resolve on itself. And if this condition is beyond control, then some patients are replaced with corticosteroid therapy. These patients will have skin bruising, as seen in this picture, where the patients have purpura on the forearm because of the reduced platelet count. Thrombocytopenia is nothing but reduced platelet count. And this is a case where the platelet count was decreased because of a bone marrow disorder before the cancer. And when there is increased loss of platelets or less platelet count is seen, then the patient will bleed spontaneously, and it will form some black palatal lesion like this. And this is nothing but a hematoma, because there is a mass produced here. And this is because of decrease of platelet count. That's why idiopathic, that cause can be sometimes unknown. Thrombocytopenic, decreased platelet count, purpura caused because of that. It's not only purpura as seen in this picture, it can be also a hematoma. Next lesion is hemophilia. As we all know what this is, it is a coagulation disorder caused because of decrease in clotting factors, hemophilia A, B, and everything. Yeah. So these patients have an enlargement of knee sometimes because they can cause repeated bleeding episodes into the joints. It's also called as hemarthrosis, and the patients are usually diagnosed earlier in their childhood. And these patients usually have hemorrhage even with the smallest routine procedure, like this example, periodontal curettage. This can be seen in patients who have severe hemophilia. Usually they can be classified into mild, moderate, severe, and everything, but mild is the case where the clotting factors are in the range of 5 to 40%. In such cases, we can carry forward the dental treatment without any interruption. But if a surgery is needed and the clotting factors are less than 5%, then clotting factor replacement should be indicated before treating such patients. And we should make a point that aspirin is avoided in patients having hemophilia because it can act on the platelets, and therefore there will be no further clot formation and they will be bleeding. The next condition is leukemia. In leukemia, as we know, it's classified as acute, chronic, myeloid, lymphoid. There are many types of leukemia, and signs and symptoms are caused because of the reduction in the normal WBCs, RBCs, and platelets because of increased malignant proliferation of other immature stem cells in the body. And these patients present with easy bruising and bleeding because of less number of normal thrombocytes. And these patients then in oral manifestations, they come with spontaneous gingival hemorrhage, especially when the count goes below 10,000 per cubic millimeter. And in this case, also petechiae can be seen on the palate, but when the leukemic cells start infiltrating the oral soft tissues, like in this picture, they produce diffuse, boggy, non-tender swelling of the gingiva as seen in this picture. Sometimes it can be ulcerated, sometimes it cannot be ulcerated depending upon the trauma to this boggy gingiva. We see the different clinical features. And we have to, as you know, this is a cancer, we cannot help much with the gingival lesions unless the underlying condition is treated. The next one is Crest syndrome. The reason for including this syndrome under is because it produces a lot of facial telangiectasias. That is nothing but a collection of small dilated capillaries. These are also called as spider veins in normal terms. And what is Crest syndrome? Along with the facial telangiectatic lesions, we also have calcinosis cutis. That is nothing but subcutaneous nodules formed because of the deposition of calcium salts. This is how the calcinosis cutis is seen. Next is Raynaud's phenomena as seen in this picture. When the patient is exposed to extreme cold temperature or the patient is very anxious, they have pallor. It looks like almost dead man's skin. And because this is due to the constriction of blood vessels. And then because of venous stasis, there is cyanosis. And when you provide them with a warmer temperature, then the blood perfusion starts again, that's reperfusion, and you can see reddening of the skin again, that is rubor. So this phenomena is called as Raynaud's phenomena. And there can be esophageal motility defect, that is difficulty in swallowing. This cannot be easily clinically diagnosed, but we have to go for barium swallow radiographs. And sclerodactyly is like claw-like formation of the hands because of increased deposition of fibers. And this is also called as extension of systemic sclerosis. There is continuous sclerosis being formed, and that's why the increased deposition of collagen forms claw-like deformity. All these things, if they are seen together, they are called as Crest syndrome. They cannot be seen at one point of time. It's not compulsory to see everything. Maybe in coming days and months, they can involve different parts of the body, and then we can call it as Crest syndrome. What are the dental considerations in such patients? Because of the limited mouth opening, because of the continuous deposition of collagen, they have microstomia, that is small mouth, and there is always inelasticity of the mucosa. And therefore, these patients will have to have collapsible dentures and modified dentures depending upon their mouth opening. And some patients cannot maintain their oral hygiene because of this deformity, because it's difficult to manipulate their toothbrush. So just to revise everything about the lesions which come under this category are petechial lesions because of trauma or some diseases like infectious mononucleosis that is spread by saliva, also called as kissing disease. And the next one is hereditary hemorrhagic telangiectasia. This is the classic manifestation seen on the tongue. Patients also have epistasis, that is bleeding from the nose, and a family history with arteriovenous malformations. This is a case of idiopathic thrombocytopenic purpura where the platelets go low because of unknown reasons, and then the patients can bleed into their skin and also the oral cavity, forming purpura or hematoma. This is a patient diagnosed with hemophilia where small minor trauma with uncontrolled bleeding can also happen. This is an example of leukemic enlargement of the gingiva. This is a part of Crest Syndrome seen as facial telangiectasias along with calcinosis cutis, Raynaud's syndrome, and claw-like deformity of the hands. These are the petechial lesions. The next one is under the category of blue and purple lesions. The first one in this category is Varix Wings. As we all know, this is seen with aging patients, usually seen in patients who are older than 60 years. And they are mostly seen in the sublingual region, that is in the below the tongue region. And they classically present as multiple blue or purple elevated papular or bleps. They are seen as purple bleps on the ventral surface of the tongue. Sometimes, but this is very rare to happen, there can be solitary varices. This usually is seen in dilated blood vessels which has thrombosis. And this is very rare to be seen, and clinically they are firm and non-tender. That's why they don't require any treatment. Next is, which we are all familiar with, is amalgam tattoo. Amalgam tattoo can come under blue-purple lesions. It can come under brown-black lesions. We'll be seeing this on on other slides also. Sometimes when we take radiograph, we can see that a part of the metallic structure which can confirm our diagnosis of amalgam tattoo. The next one is blue nevus. This term nevus will be discussed again and again. So what exactly is nevus is it refers to the malformations of skin or mucosa, which can be developmental or congenital. So this, as the name suggests, is blue in color. It is uncommonly seen, not that frequent. It is caused because of the benign proliferation of melanocytes, which are responsible for the color of the skin, obviously. So this condition is caused by the benign proliferation of the melanocytes in the connective tissue. And the oral lesions are most commonly found on the palate in children or young adults. And usually these lesions are smaller than 1 centimeter in diameter. They can mimic easily early melanomas. So just one rule is, whenever we see pigmented lesions in the oral cavity, which occurred while development or congenitally, it is always better to have a biopsy done whenever we see a pigmented macule in the oral cavity, because such lesions can turn into melanoma. The next one is the most common salivary, minor salivary gland lesions, that is mucocele and ranula. We all know mucocele is caused by the trauma to the minor salivary gland ducts. It can be two types, extravasation or retention. So whenever there is trauma to the salivary gland, minor salivary gland ducts, this type of blue lesions can be seen. Depending upon the depth of these lesions, it can change its color. Usually they are bluish. And the history, patients always have a history that they form, rupture, and reoccur again. So this cyclic swelling and rupturing is often seen in mucocele. And if it is seen in the lateral floor of the mouth, it is deep-seated, that is ranula. So mucocele and ranula can occur as blue lesions. Sorry. The next one is eruption cyst. It is also called as eruption hematoma. This is considered as a soft tissue analog of the dentigerous cyst. So dentigerous cyst, as we all know, is a manifestation seen in the bone. If it occurs in the soft tissue, it's called as eruption cyst. This usually occurs mostly in children less than 10 years of age. As the name indicates, it can be seen associated with any erupting tube. Usually these lesions are translucent, but when there is trauma to this translucent cyst, there is bleeding in the cystic space, and that's why it appears as blue-purple. And that's why when the patient comes in with the swelling, there can be a blood accumulation in this. And how do we deal with this? Just reassure the patient that the eruption hematomas will rupture spontaneously. If not, in rare conditions, we may have to give a simple excision of the roof of the cyst so that it will have speedy eruption. Next is gingival cyst of the adult. This is seen in children, this is seen in adults. And this is a soft tissue counterpart of lateral periodontal cyst. Lateral periodontal cyst is seen inside the bone, and this, if it occurs on the soft tissue in the same region, that is between the canines and the premolar, it is called as gingival cyst of adults. This also, depending upon depth, can be appearing as bluish lesion. It has a slight predilection towards the mandibular, canine, and premolar, but in rare condition can also occur in the maxilla in the same regions. How do we treat this? This is also treated by simple surgical excision. The next one, which appears purplish, is hemangioma and vascular malformations. These two are definitely vascular lesions, but they both are different. Hemangioma is different than vascular malformation. Hemangiomas are benign tumors of infancy, and they have endothelial cell proliferation. Obviously, we cannot see this clinically, but histopathologically, they have endothelial cell proliferation, but vascular malformations have no such proliferation. And these are usually seen at birth, but cannot be diagnosed sometimes soon after the birth and can be seen after a few months. Hemangiomas show one characteristic feature. At some point of time in life, they have and they display a rapid growth phase. For about 6 to 8 months, they keep growing rapidly. But on the other hand, vascular malformations, these are also the structural abnormalities of the blood vessels, but they are present at birth and they are persistent throughout life. They do not involute. Hemangiomas, they grow with a rapid phase and then they start involuting. That is, they start to regress in size. But it is opposite to that of malformation. They stay throughout their lives. Oh, okay, sorry. I don't know, my screen was blank or something. Okay. So sometimes these hemangiomas can be treated by surgical excision, as in this case, if it is so small in size, but sometimes they can be too extensive, and such lesions can be treated with intralesional steroids or some sclerosing agent. Whereas vascular malformations, again, depending upon the size, it requires resection, that is surgical management. But if these lesions are quite extensive, then it requires radiographic embolization of the feeding vessel before the surgery, just to avoid the extreme blood loss. Next, which appears bluish in color, is salivary duct cyst. The salivary duct cyst is an epithelium-lined cavity, so it's a true cyst. And this cause is uncertain, but some authors have said it is because of the ductal obstruction because of some reason. And when the duct is obstructed, there is increased intraluminal pressure, which causes to the formation of the cyst. This lesion can occur in adults and can even arise in major salivary glands, or it can occur in minor salivary glands. As shown in this picture, this is a floor of the mouth where there is opening of the submandibular gland ducts, and opening of this duct, we have a small cyst, that is the Walton's duct, and it appears as if there is a nodular swelling. And the same thing, this is a case reported with swelling, which cannot be appreciated much, but this is where the swelling is. It appears as if there is a node on the upper lip, and after the surgical excision, it was confirmed by histopathological diagnosis that it is a salivary duct cyst. And this can vary in consistency. Sometimes it can appear as soft, sometimes it appears as a firm nodular mass, but the size usually does not exceed 2 larger centimeters. Next is kaposis sarcoma. This is a multifocal neoplasm of the vascular endothelial cell origin, but this sarcoma is usually associated with HIV infection. Usually when the patient is immunocompromised, these lesions can set in and demonstrates in the oral cavity. But once the same patient has attained immunocompetence, these lesions regress in size. So some authors really have a question to if really to call it as a sarcoma because it's a malignancy. But whenever the patient undergoes immunosuppression, these lesions are seen in the oral cavity, and when they are treated and they are immunocompetent, these lesions sometimes tend to regress, but not always. It also requires sclerosing agent therapy. That is, it can be injected when it grows to this size to avoid trauma to this. Intralesional vinblastine, that is a chemotherapeutic agent, or a sclerosing agent is also used to treat this. Invariably seen in patients who are associated with HIV infection. It can occur in various sizes, shapes, and forms. As in this picture, you can see there is a slight discoloration on the palate here, which is in the shape of M, just the discoloration and nothing else. And the same kaposis sarcoma can also be seen as a red enlargement of the anterior facial gingiva. And this here, it produces a nodular enlargement. So it can be seen in different forms. But the one characteristic feature it is always associated with immunocompromised state, that is HIV AIDS patients. Next lesions which can appear slightly bluish in color is salivary gland tumors. Not always, but sometimes pleomorphic adenoma can occur in minor salivary glands, not only in the major salivary glands, but also in minor salivary glands, which are distributed throughout the mouth. But these are seen usually in the palate. And when such lesions occur, part of it is bluish, but not all for sure, but not for all the lesions. We cannot say that it is always blue in color. It is covered by normal mucosa. Sometimes if it is traumatized, it can be ulcerated, but few lesions like pleomorphic adenoma and mucoepidermoid carcinoma, they usually have this pale blue color and seen in the posterior part of the palate, and sometimes it crosses the midline. To summarize all the blue and purple lesions which we saw now, the first one, this is Varix Wings, seen in elderly people, which is a normal dilation of the veins and no treatment is required. This is ranula and mucocele salivary gland lesions, can occur because of trauma to the minor salivary glands. Sorry. Next one is vascular malformation or hemangioma that can also be seen as blue or purple lesions. Salivary gland duct cyst, depending upon the depth, it occurs as blue or here it's amber. Different forms and shapes of kaposis sarcoma always associated with HIV and pleomorphic adenoma as in this case. So these were the examples of blue lesions. The next one is brown, gray, or black lesions. This is a common presentation depending upon the race, usually seen in dark-skinned individuals. When they are dark-skinned or dark complexion, even their oral mucous membrane can also be a bit darker when compared to other races, and this is normal and does not require any treatment. Next one is smoker's melanosis. Whenever the patient has a habit of smoking, there is black diffuse melanin pigmentation seen in the gingiva. Usually it occurs only on the buccal surfaces, the front surfaces of the gingiva, and it is not seen usually in the posterior surface, only on the anterior facial gingiva. Thus, that does not require any treatment too. Next is black hairy tongue. As we saw white hairy tongue, as I told earlier, This can take any color. If this is caused by increase in the growth of filiform papilla on the dorsum surface of the tongue, and if it's not scraped and cleaned, it leads to accumulation of color depending upon the exogenous environment. Here in this picture, it is associated with the chromogenic organisms, and sometimes certain medications like doxycycline and bismuth can also contribute to this black color caused by growth of filiform papilla. Ask the patient to brush the tongue properly, and this will be gone within 2 weeks. Next one, as I told in the previous slides too, amalgam tattoo can occur purple, black, gray, blue, and it's simply straightforward diagnosis because you will find some amalgam restorations in the vicinity. Here, the amalgam restoration is only on 6, but we see it on premolars and canine as well. Why? Soon after the amalgam restoration, the patient used floss, with before that was totally set. As we know, it requires a long time to set, and he flossed all the interdental lesion and impregnated the amalgam particles, and that's why it formed amalgam tattoo. And whenever we have endodontic related amalgam implantation, that is when we do retrograde filling using amalgam back in those days, that can also cause black patch, like in this case. And this is another example of mucosal discoloration because the patient has amalgam restoration here, and that's why we have amalgam tattoo in the floor of the mouth. Different drugs, for example, chloroquine, chlorpromazine, minocycline, and bismuth, like many drugs can cause discoloration of the oral cavity, as we all are aware. Minocycline has tendency and affinity towards the bone, and long-term therapy with minocycline led to the discoloration of the facial aspects of the anterior bone of the mandible, because the attached gingiva is very thin and the alveolar mucosa is very thin in the anterior mandibular region. Staining of the bone can be seen through this thin mucosa, and this is minocycline related. Another example which is seen on the palate here is multifocal areas of palate pigmentation because of deposition of minocycline, as it is chelated to iron, and this will happen on long-term basis when the drug is taken in the long-term basis. Chlorpromazine also causes grayish diffuse pigmentation of the hard palate. You cannot make out the boundaries, but the borders are really diffuse and merging with the surrounding normal mucosa. Next one is heavy metal poisoning. The metal can be bismuth, it can be lead, and this is formed because wherever there is bacteria causing this gingivitis, these bacteria acts on the lead, which is already present in the gingival surface, and the bacteria and lead, when they react, they produce a hydrogen sulfide, and they precipitate to form lead sulfide, and they cause this discoloration along the gingival margins. I'm not sure if you all can appreciate, but this one here, this line can be seen along the gingival margins, and upon history, we can see that the patient would be taking lead on chronic basis. Here is an example of heavy metal poisoning due to silver. It's also called as argyria. You can appreciate how the patient has discoloration of the face when this is taken with this another lady, just to compare, because before taking this silver containing nutritional supplement, the patient had similar complexion, and now her complexion has changed because of the silver containing nutritional supplement. Okay, the next one in brown black lesions are different black lesions which are occurring in the mouth, and next 2 slides, that is melanotic macule, melanocytic nevus, melanoacanthoma, malignant melanoma. All of these requires biopsy to differentiate it from each other. So we must make sure that, as I told earlier and mentioned it in the previous slide, whenever we see any occurrence of black or brown patch or macule in the oral cavity, it's always advised to biopsy, because any of such simple appearing and benign appearing lesions can convert into malignant melanoma. So what is the difference between this melanotic macule and melanocytic nevus? It's all histopathological. Here in melanotic macule, there is increased in the pigmentation, melanin deposition. Increased melanin deposition causes macule, whereas increase in the number and proliferation of melanocytes causes nevus. So it's all histopathological, mostly. And here it is flat, oval, brown macule, and can be seen anywhere inside the mouth or on the lips, usually seen on the lower lip vermilion, can occur on the gingival mucosa, it can occur on palate, but this has a slight predilection towards females, that is in the ratio of 2:1, and occurs in mid-adult life, like around 40 years. Whereas the melanocytic nevus can be both acquired or congenital, meaning this can be seen around the age of 30 to 35, again with female predilection, whereas congenital melanocytic nevus can occur in patients who are like 3 years old or young children, because this is congenital. And why is this different from acquired? Is that congenital melanocytic nevus have a 3 to 15% chances of turning and transforming into malignant melanoma. Whereas if it's acquired, no, it's benign. It's not going to transfer into melanotic melanoma. But congenital nevus can transform into malignant melanoma. So these lesions have to be under continuous watch, especially if these lesions are larger in diameter. The larger the diameter, the higher the chance of transformation into malignant melanoma. The next lesion which crosses the brown or black lesion is melanoacanthoma. Excuse me. This is another example where the lesion, the dark pigmented lesion or the macule of the buccal mucosa can grow at a very rapid pace. For example, in this picture, this was the patient seen. Oops. Okay. So this was the patient seen on the first visit, and when he came 2 months later, you could see the enlargement of this macule to such a dramatic size. So when the lesion was biopsized, there was incisional biopsy done, you can see that there is resolution of this macule or the lesion. I don't know, for some reason my screen is going on and off. I don't know if it's displayed. Okay.
We're not having issues viewing, Dr. Javali.
Oh, thank you for the confirmation, Dr. Sally. I don't know. Thank you. So yeah, coming back to the slide, this oral melanoacanthoma can occur in 3rd to 4th decade of life. Usually this is a reactive lesion to some irritation or continuous irritation, and not because of any malignancy or any change. Because there is alarming growth rate, it is a must to do the biopsy of such lesions just to rule out oral malignant melanoma. And this lesion is not life-threatening. Once you biopsy or remove or excise this lesion, it's going to subside and it's not going to reoccur again. Usually this can be seen in people who are dark brown to black skinned, and not and less frequently seen in white skinned people. Next is malignant melanoma, and this is what I was talking about from the first slide. Any lesion which is black or brown appearing as a macule has to be incised and sent for a biopsy examination, because it can anytime turn into malignant melanoma. But there are some clinical features which can alarm us and point that this can be a malignancy. And those are called as A, B, C, D, E. These are the clinical features of malignant melanoma. A stands for asymmetry. These macules, which start as a macule, as you can see in this picture, this simply looks like a melanotic macule, or you can call it as a nevus. But when the specimen was sent for histopathological examination, it was diagnosed as malignant melanoma. This was a case reported as malignant melanoma. This can be seen as small as this to a big pigmented mass like this. So depending upon the stage. So first clinical feature is asymmetry. You are not having a symmetrical growth. It can grow in any form, any shape. And when you look at the border, it has irregularity. It is not well-defined and sharp and symmetrical borders. And there is color variation. And the diameter can be more than 6 millimeters, but not always the case. As you see in this one, it's almost approximately 5 millimeters. But clinically, if anything is more than 6 millimeters, then it should give us a hint that this can turn into malignant melanoma. And the lesion keeps changing. And the patients also can say that it changes in size, shape, color. The patient sometimes can say that it is symptomatic. Symptomatic only when it is ulcerated because of secondary trauma and it's get infected. And when we take the radiographs of such lesions, we can see not this tiny, but the lesions which are fully blown like this, we can see moth-eaten destruction. And that is about malignant melanoma, and we have to excise this lesion surgically. And usually when the patients are diagnosed with malignant melanoma, there's 5-year survival rate is in the range of maybe 10 to 20%. That's it. And that's the reason for this is because of the hematogenous metastasis. This lesion can undergo rapid metastasis by blood vessels. So the next syndrome is Buerger syndrome. It's called a syndrome because definitely it has a collection of other signs. That is, in this patient, you always have lesions, freckle-like lesions, as seen in this patient. You have the lesions on the perioral skin, that is around the mouth. We have freckle-like lesions on the mouth, sometimes on the skin, plus the patients have polyps in the intestine. And these patients, that is patients with Buerger syndrome, where they have freckle-like pigmentation and intestinal polyps, such patients have increased predisposition to developing cancer. And these lesions, as they're seen around the mouth, can continue inside the oral cavity, especially on the tongue, buccal mucosa, and the labial mucosa in almost more than 90% of the patients. So you can have such lesion also inside the mouth. And these patients should be closely monitored for the development of any tumors, and genetic counseling is the only way, and we cannot do much to help such patients. But a few patients can be diagnosed solely on the oral lesions, and they can be referred for further investigations. The next systemic disease which can be manifested in the oral cavity is Addison's disease. This is nothing but produced because of insufficient production of steroid hormones in the body. And that can be caused because of destruction to the adrenal cortex because of various reasons, autoimmune, infection, tumor. Anything can cause destruction of the cortex and less steroid hormone secretion, and this causes Addison's disease. The first oral manifestations of Addison disease is diffuse pigmentations. They can be seen as macules throughout the oral cavity, as seen in this patient in labial mucosa, and also here. This is a huge macule seen on the ventral surface of the tongue. And this can also be accompanied by skin hyperpigmentation, but sometimes oral lesions appear first and the skin lesions appears later. And this can easily, as you see in this picture, can be manifested on the facial aspects of gingiva as well. Remember, there was another picture like this, which showed like racial pigmentation. How do we differentiate if it is normal racial pigmentation or pigmentation due to Addison's disease? One hint is that the patient will accept that this occurred as a recent onset. If it is a history of recent onset of pigmentation in the anterior gingiva, that gives us a hint that the patient has Addison's disease and not facial pigmentation. And how do we treat this? We have, because the patient has deficiency of steroid hormones, supplement extra with steroids like 5 to 7.5 mg of prednisone. What is the importance in dentistry? If there is routine dental procedures which are done under local anesthesia and last for less than an hour, then no dose adjustment of steroids is required. But if any surgical procedure has to be done, which is longer than an hour or requires the general anesthesia, then steroid dose should be adjusted. So just a quick summary of brown and black lesions. Racial pigmentation, pigmentation produced because of smoking called as smoker's melanosis, black hairy tongue because of chromogenic bacteria or drug pigmentation. Amalgam tattoo will have amalgam in the surrounding region. Pigmentation of the palate secondary to drug ingestion. This is again heavy metal intoxication, that is lead called as bismuth lime. It can be bismuth or butonium, anything. So heavy metals in short. This less than 7 millimeter brown oval macule is called melanotic macule. Another black lesion on the palate can be acquired or congenital, melanocytic nevus. Oral melanoacanthoma, which has a propensity for rapid growth. And next pigmented black lesion can be malignant melanoma. It can take any form, small macule to huge mass, which is black. Next one is Crest syndrome, which occurs like freckles. One clinical features which can differentiate it from freckles, because this almost looks like freckles, it can be seen also on the skin, is that this freckle-like lesions do not change with the seasons, whereas we know that the freckles show changes during the summer season. But this remains constant, it's not going to change. And this is another example of systemic disease, that is Addison's disease. This is a summary of brown-black lesions. Last one is yellow. So this is the most common variant, almost seen in almost every other patient, the Fordyce's granules. These are ectopic sebaceous gland inside, which are trapped inside the oral mucosa. And this does not require any treatment. Most commonly seen in the labial or posterior surfaces of buccal mucosa or on the vermilion of the upper lip, and sometimes also on the lower lip. Next is accessory lymphoid aggregate. These can occur anywhere inside the oral cavity, wherever there is chances of lymphoid tissue aggregate. This can mimic, as you see, this lesion can mimic mucocele. It can mimic lipoma, depending on the color. Mucus is usually blue, light blue, pale blue in color. Lipoma is yellowish in color. But sometimes lymphoid aggregate, as the name says, it should appear in groups or several numbers, like 1, 2, 3, 4 more aggregates here. Sometimes it can occur as a solid region. But this has an orange to yellow hue. So that's a hint that it is a lymphoid tissue. Histopathological examination is important to rule out anything. And this is seen as a smooth, small, round, painless swelling, and it has intact and normal appearing mucosa. It is usually less than half a centimeter in size. So that's another hint. This is not going to grow in size. We all know superficial abscess secondary to some dental infections like this, periapical abscess, if it is superficial or condensed or it is localized, can appear as yellow lesions. The next one is lymphoepithelial cyst. This can be seen anywhere where there is oral lymphoid tissue. It can be seen wherever there is tonsils, lingual tonsils, maybe in the pharyngeal area. And this is always filled with keratin or some cheesy material when we see the sections. Clinically, it is always less than 1 centimeter in diameter, and it is smooth surfaced, non-ulcerated, usually yellowish in color. Next is lipoma. Lipoma is nothing but a benign tumor of fat, therefore it appears yellow. It is always almost asymptomatic. There's no pain, nothing which bothers the patient. It is smooth surfaced always and occur less than 3 centimeter. It is not going to go more than that. Seen in patients who are in adult age, that is 40 to 45 years of age, and the treatment is to simply excise them and there is no recurrence. It is always soft to palpate. And if it is superficial, because it is a tumor of fat, it appears yellowish in color. Jaundice, we all know it's a condition characterized by excess bilirubin in the bloodstream. That's why all the mucosal surfaces appear yellowish. The next lesion is Biostromaticus vegetans. This is an oral expression of the bowel disease, also called as ulcerative colitis or Crohn's disease. It can be an oral manifestation of those inflammatory bowel diseases. The classic feature of this is snail track pustules, meaning it can form serpentine or linear, elevated, yellow type of ulcerations. And they are called as snail track because they appear like serpentine. These lesions can occur when there is the bowel involved, or sometimes before that. Oral discomfort is minimal, and medical management of the bowel disease with systemic steroids causes clearing of these oral lesions. If this manifestation is mild, it's only oral manifestation and no much inflammatory bowel involvement, then topical steroids can also cause clearing of these lesions. The last lesion is verruciform xanthoma. It is a hyperplastic condition of the epithelium, and there's no clear cause, but they have suspected human papillomavirus. It's not always yellowish in color. It can sometimes appear white and sometimes appear yellow. So this is very characteristic. It appears like tiny dot-like structures. There is tiny papillomatous-like structures, finger-like projections, which are very, very minute and tiny. The treatment is to simply excise that surgically. And it is seen in middle age, like mid-adult age, 40 to 60 years of age. It is always painless and it is broad-based. It appears yellowish and finger-like projections. It is called verruciform. Verruciform itself meaning papillary. So it appears as the papillary growth. Quick summary: polyposis granules, lymphoid aggregate. It can be seen as a single or multiple lesions, superficial abscess, lymphoepithelial cyst, lipoma, jaundice because it causes generalized yellow discoloration, Biostromaticus vegetans, which is oral manifestation of inflammatory bowel disease, and the last is verruciform xanthoma. Thank you. Thank you for the patient listening.
Thank you so much, Dr. Javali. I honestly regret not being able to attend last week. I will definitely watch the recording. It is very thorough and very informative and very nicely summarized. I think everyone agrees with me when I say that.